All right, I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation's educational webinar series. I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we'd like to thank our sponsor, Novartis, for supporting these webinars. Today's webinar is what you need to know about granulomatosis with polyangiitis, or GPA, with Dr. Audra Hornomanski. And after we finish the webinar today, there'll be a recorded version on the Vasculitis Foundation's YouTube channel. Everyone who's registered today will receive an email with a link to it as soon as it becomes available. That way, if you want to share it or rewatch it, you're able to do that. At this point, I'd like to introduce our guest speaker today, Dr. Audra Hornomanski, who is an assistant professor in the Division of Immunology and Rheumatology at Stanford University. She earned her undergraduate degree from Case Western Reserve University and her medical degree from Wright State University Boonshoff School of Medicine. Dr. Hornomanski completed her internal medicine residency and rheumatology fellowship at Stanford. She serves as the director of the Stanford Vasculitis Clinic and leads research focused on vasculitis and pregnancy outcomes. So welcome, Dr. Hornomanski. We're so happy to have you here with us today.
Thank you so much. I'm so excited to be here.
And I think before we get started, we're going to do some polls so that we can see exactly what our people that are watching today, patients, caregivers, whoever they are, hopefully you all can see the polls and participate in them at this point. I have put it up there, and there are 4 questions for you to answer. Okay, Dr. Hornomanski, hopefully you can see the results at this time. Did you want to comment on any of those questions and their answers?
Well, no, I like it. This is actually super cool because some of the things that we're going to talk about today are like directly related to these questions. But it's exciting to see so many people who had their vasculitis diagnosis less than 3 months after symptoms began. That's actually quite uncommon. The time to diagnosis can be really, really long, which definitely is reflected in those people that said more than a year. And then the spectrum of symptoms is quite similar to what we see in larger studies. So this is like a really it's a good representative sample of patients who have vasculitis, and similar with the treatment distribution. The vast majority of people having received some sort of prednisone or other corticosteroids, and then a good number of people that have received our newest medication, Avacopan, which is super interesting. So no, that's really exciting. And also lastly, great to see so many people are in remission and doing really well. But I'm excited to, give some education and talk to those people who are not.
Okay, thank you for commenting on that. Thank you, everybody, for participating. That really gives us a good idea of who's watching today. So I'm going to stop sharing now, and before you start sharing your screen, or go ahead and share your screen, Dr. Hornomanski, I would like to know, or we would like to know, if you have any disclosures today.
Yeah, so I don't have any disclosures related to any of the content that we're talking about today. I do clinical trials in other diseases, but I don't receive any funding from any pharmaceutical companies related to any of the medications or any of the upcoming research that we're going to be discussing today.
Okay, great. We would love for you to share and teach us all about GPA.
Okay, so as Kathy said, today we're going to be talking about what you need to know about GPA, and this is directed at patients, families, caregivers, anyone who is experiencing this disease in any form in their life. So a little bit about me, since I don't know probably most of the people on this webinar. I'm Audra Hornomanski. I'm the director of the Stanford Vasculitis Clinic, where I care for patients with all types of systemic vasculitis from a quite large geographic area. We're located in Palo Alto, California, but because there are so few vasculitis centers around the country, I see patients from the vast majority of California, kind of down to the Fresno area, all the way up to the Oregon border. I have many patients from Nevada. There's very few physicians who care for vasculitis in Western Nevada in particular. Also have patients from Hawaii as well. And so a quite large geographic area. And I work with a wonderful interdisciplinary team because these types of vasculitis, they can affect so many different organ systems in the body. So it's super important to have a wonderful, really collaborative interdisciplinary team. Another part of my job is that I'm the program director of the Stanford Adult Rheumatology Fellowship. So it's part of my job to help train our rheumatology fellows workflows and how to recognize and treat systemic vasculitis. I am involved in a variety of different research efforts, but my primary focus is on pregnancy outcomes in patients with systemic vasculitis. And I was honored enough to receive one of the Vasculitis Foundation's grants this year to look at the use of azathioprine during pregnancy in patients with vasculitis. Other research I do is on imaging in large vessel vasculitis. And like I mentioned previously, I'm involved in a number of different clinical trials. The goal for today is to empower you with clear, up-to-date information about you or your loved one's condition so that you can be an informed partner in your care, especially with diseases like this, which are long-term chronic diseases. It's so important for patients to be an active member of the discussion when we're talking about potential treatment options and prognosis and things going forward. So, understanding granulomatosis with polyangiitis, which is a very long name, so going forward, I'll refer to it as GPA, or our typical abbreviation. So GPA, it's a rare autoimmune disease that causes inflammation of blood vessels, most commonly the small and medium-sized blood vessels. Very rarely it can affect large blood vessels. This inflammation is called vasculitis, and kind of if you break down that word, the vas meaning vessel and itis meaning inflammation, so it kind of makes sense there. GPA is one of 3 ANCA-associated vasculitides, and it's named due to the ANCA antibodies that are frequently positive, although not always positive. That's why it's ANCA-associated vasculitis and not ANCA-positive vasculitis, for example. We're going to discuss those ANCA antibodies in detail a little bit later. The other diseases under this ANCA vasculitis umbrella are microscopic polyangiitis, or MPA, and eosinophilic granulomatosis with polyangiitis, or eGPA. We won't be discussing those 2 diseases today, so we're going to focus mainly on GPA. GPA has 2 main clinical features: that vasculitis that we mentioned before, that inflammation and damage to the blood vessel walls, and granulomas, which are these clusters of inflammatory cells that can form in tissues. And sometimes that manifests as like nodules or mass-like lesions that can occur throughout the body. One of the most common questions that I receive in patients who are newly diagnosed with GPA is, what caused this? Did I do something that caused this? And I want to reassure everyone here today and all of my own patients that there is nothing that you as a patient or your family member did to cause this disease. And truly, most autoimmune disease is a perfect storm. Most patients who have autoimmunity have some sort of genetic predisposition. However, the majority of people with a genetic predisposition will never go on to develop an autoimmune disease. But in that subset of people, there's some sort of trigger that happens in their environment, and that trigger can be many, many things. Sometimes it's an infection, so commonly things like strep or staph infections, or in the case of the COVID pandemic, we saw a lot of new autoimmune diseases that developed after COVID infection. And basically, if you think about it in the way that your immune system becomes very active when it is fighting off some sort of infection, and sometimes it can become overactive or active in an inappropriate way. And that's really what's happening when an autoimmune disease starts. Sometimes we see it in hormonal changes. So the postpartum period in particular is a really common time to develop autoimmune diseases, unfortunately. If you can imagine that during pregnancy, your immune system becomes very tolerant because it is trying to not reject the baby. But after pregnancy, your body goes through lots of different hormone changes, and sometimes it overcorrects and ends up becoming less tolerant or very autoimmune. And that in and of itself can trigger autoimmune diseases. There's definitely things like environmental exposures, which are kind of growing in interest in their implication in triggering of autoimmune diseases. So things like wildfire smoke or pollution, for example. There's, especially in more common autoimmune diseases, there's some quite robust data for the association there. And then some very specific exposures, things like silica, for example, have a high association with autoimmunity. Okay, so once that kind of cascade starts, patients present with a variety of different symptoms. And it's important to say up front that because the smallest blood vessels in the body exist in every single organ system, this disease can affect every single organ system. And as somebody who runs a vasculitis center, I get a lot of patients who have unusual manifestations of these diseases. And so I have seen it affect almost every part of the body. We'll highlight the most common today, which was a lot of the things that were highlighted in the poll question up front. And I'll say the most common presenting sign and symptom kind of far and away is ear, nose, and throat manifestations. So ear, nose, and throat symptoms are present in 90% of GPA patients. The most common things are crusting, congestion, nosebleeds, or recurrent sinus infections. So I put in, if you can't see me on the video, I put infections in quotes because they're not truly infections, but they feel a lot like infections, right? So that like congestion, drainage, a lot of sinus pressure, a lot of sinus headaches that will sometimes get treated with antibiotics and not really improve or very, very slightly improve. But then sometimes sinus infections end up getting treated, especially by ENT doctors, with steroids in addition. So prednisone or prednisone dose packs, Medrol dose packs, those types of things. And that will temporarily treat the autoimmune problem, but then the sinus quote unquote infection will come back and patients will experience those symptoms all over again. If that inflammation in the sinuses persists for long periods of time, it causes destructive sinus disease, which is why it's really important for patients to get diagnosed appropriately. And unfortunately, patients who have primarily sinus symptoms, which is about 10% of patients will really only have like sinus symptoms, or we usually say like disease from like the neck up. Those patients have some of the longest times to diagnosis because they get misdiagnosed as allergies or just recurrent sinus infections or other more common sinus pathology. There have been several studies that have shown that the time to diagnosis in that subset of patients is frequently over 5 years on average. Sometimes when they finally end up in my clinic, they've already had significant sinus destruction, and that can manifest as a number of different things. So nasal septal perforation, which is like a hole in the septum, can occur. Sometimes you'll see external deformities of the nose as the inflammation can cause collapse of the nasal bridge. Other things, and ones that's highlighted here, is that sometimes the inflammation can extend through the sinuses and also cause hearing loss. So some patients will initially present with hearing loss as one of their earliest symptoms. But ENT symptoms, as we're going to talk about throughout, are incredibly common in patients with GPA and really important that we treat appropriately. One of the next most common symptoms is pulmonary symptoms or lung symptoms. So this can present as shortness of breath or cough, sometimes coughing up blood. That's a much more severe manifestation of this disease. And also to say that the acuity or the severity of the presentation of GPA is vast. So some people will have this like smoldering like sinus symptoms that will go on for years and won't ever become what we call organ threatening or severe enough to admit someone to a hospital. And then other patients will have kind of a couple of months of these symptoms before it really becomes more urgent. And then some people like will have felt completely fine and then a week later have developed incredibly severe manifestations. And so sometimes that's the pulmonary symptoms when there's so much inflammation in the lungs that it causes bleeding into the lungs, and that leads to people coughing up blood, and that can be life-threatening in some cases. Patients can also present with an asthma mimic, which is like wheezing that comes from narrowing of the airways. So in addition to causing inflammation in the kind of broader parts of the lungs, it can also cause an inflammation in the passageway of air. And that can be what is called the subglottic area, which is in the throat as it leads down to the lungs, and also the bronchioles, which is the main tubes that lead to each individual lungs. Inflammation in those passageways can cause narrowing of the airways. And if the airway is narrow, then that can cause wheezing and in a lot of cases feel like and sound like asthma. Sometimes patients are diagnosed a little bit more incidentally where they'll be found to have nodules or different haziness on chest imaging. And the cause for those different types of nodules or different areas of haziness or sometimes called ground glass opacities is really broad and needs a very thorough workup, which we're going to discuss in a little bit. Other common presenting signs, and one of the most serious of those is kidney disease. And it's really important to note that most people don't have symptoms of kidney disease until it's quite late. So your kidneys do a really good job of kind of buffering things as they're filtering our blood. But it really takes quite a bit of kidney dysfunction for patients to develop symptoms. So patients can get swelling of the legs, they can get various laboratory abnormalities. So on the photo here, it shows increase in creatinine. Blood and protein in the urine are the kind of the hallmark of the urinalysis findings that we'll see. Sometimes in very advanced cases, patients will get frothy or foamy urine, and very rarely patients will get frankly bloody urine that you can see. We most commonly see blood in the urine that is visible on urinalysis or the urine test, but isn't visible to the naked eye. And then a large percentage of patients will have what we call constitutional symptoms, which are somewhat non-specific as they can present with a lot of different diseases. So things like fevers, fatigue, unintentional weight loss, and then just kind of muscle and joint pain that can migrate throughout the body or can kind of come and go. Unfortunately, these specific symptoms, as I said, are really non-specific in that they can be present in a lot of things. You know, if you have an infection or pneumonia or a cold or a lot of other conditions can also present as this. And so it can also lead to some delay in the diagnosis. There's a lot of other additional symptoms which are associated with GPA. Some people will have skin disease. So rashes in GPA are relatively common. They're typically what we call petechia or purpura, which are these kind of dark red to violet appearing either very small dots to kind of large, more like what we call confluent patches, where a lot of the small dots come together. They are usually on the lower extremities, the legs, but they can affect the whole body. These types of rashes are more common when the disease is more active, of course. Inflammatory eye disease is also well described in GPA, and that can take a number of different forms. So you can get inflammation within the eye itself or within the different layers of the eye. So you have all these different components of the eye, for example, the retina, which is the farthest part in the back part of the eye, or the sclera, which is more on the front part of the eye. And sometimes that causes a variety of different symptoms. So when you have inflammation of the sclera, it causes a lot of redness, a lot of pain in the eye, even with movement, and a lot of irritation. Whereas inflammation of the retina won't really be visible from the outside, but causes painless vision loss. Some patients with GPA will also get those granulomas that form kind of mass-like lesions around the eye, and that can then push on the different structures of the eye. For example, the optic nerve, which is the main nerve that allows us to see, and that can limit vision or cause vision loss or cause pain within the eye itself. Patients can also get what we call vasculitic neuropathy, which is when the vasculitis affects the nerves of the body. This is actually much more common in the other subtypes of ANCA vasculitis, more common in MPA and eGPA than it is in GPA, but it certainly still can't happen in GPA. This is more commonly in kind of the arms and legs. Patients will present with numbness or weakness, and this is due to direct inflammation of the blood vessels that supply the nerves. And this is not an exhaustive list of things that the disease can cause. I have seen it, as I said, affect every organ system in the body, from very unusual things, for example, involving the brain. I've seen it cause pancreatic masses and pancreatic inflammation, GI inflammation, or things that can cause bloody stool. It really can affect almost every organ system in the body. So that's part of the job of the rheumatologist, is to make sure that they're thinking about all of those different organ systems and how the vasculitis could be affecting those different areas. Okay, there's a lot of different diagnostic tests that are required to help us figure out if a patient has GPA. The basic ones are the ones that you're probably very familiar with. So things like a complete blood count or a CBC, or a complete metabolic panel, sometimes called a CMP. These tell us if there is a high level of white blood cells, if there's anemia that's ongoing, both of which can be signs of the vasculitis, but again, quite nonspecific. Sometimes patients will also have elevated platelet counts, which are a sign of inflammation. The metabolic panel is quite important to help us look at the kidney function. The urinalysis is critically important to help us look at the kidney function as well. Remember, we're looking for that blood or protein in the urine. All patients who come to me for an evaluation of GPA also get a urine toxicology test, and that is to look for various different drugs of abuse that can cause positive ANCA tests, but also quite perfectly mimic ANCA vasculitis, cocaine being the best mimic. And so especially patients who have kind of destructive sinus disease, cocaine is unfortunately quite a destructive drug that causes similar inflammation in the sinuses as well as that sinus perforation that can happen. And the cocaine in and of itself can cause an autoimmune phenomenon that looks a lot like ANCA vasculitis. And so I always try to reassure patients that all patients who come to me for this diagnosis end up with a urine drug screen, and that's not a moral judgment on any patient, but it's really, really important that we rule in or rule out those as a potential cause. We also want to do various different infectious tests because different infections can mimic and look like ANCA vasculitis. And also it's important to have a number of different tests be negative before we treat ANCA vasculitis. And so those are things like a TB test, sometimes called a quantiferon, and then hepatitis B and C and HIV tests are all need to be negative before we pursue most of the treatments for this disease. Then we kind of move on to the more specific immunologic tests. So ANCAs, MPO, and PR3, and then others, depending on the different organ systems that are involved. So you may have seen your doctors check things like an ANA or a GBM, or also called glomerular basement membrane antibody, or complement levels, which are C3 and C4. Those ANCA antibodies, ANCA stands for anti-neutrophil cytoplasmic antibodies. GPA commonly has a positive C ANCA, and we have these, so there's two different ways to look at ANCA. There's the ANCA test itself, and then there's the MPO and PR3, which are kind of our more specific antibodies. The C ANCA pattern or cytoplasmic ANCA pattern is more commonly associated with GPA. And similarly, the PR3, also called proteinase 3 antibody, is more commonly associated with GPA. But some patients can also have the p-ANCA or perinuclear ANCA pattern or the positive MPO antibody. About 90% of patients with GPA have some sort of ANCA positivity, and that could be the C-ANCA, p-ANCA, MPO, or PR3. So only about 10% of patients are ANCA negative. So being ANCA negative doesn't rule out the disease entirely, but it does make it somewhat less likely. Other really important diagnostic tests, we're always looking for objective evidence, meaning something that I can see that's going to tell me for sure that this is due to ANCA vasculitis or GPA in this case, versus other conditions that can look very similarly. So frequently we will order biopsies of the affected tissue, and that can be all of these listed here. So it depends on the areas or organs that are involved. So sometimes we'll do skin biopsies, which are kind of the easiest of the biopsies to get. But if the lungs or kidney are involved, it's very important that we do lung or kidney biopsies. We will sometimes do sinus biopsies, although the yield on sinus biopsies is relatively low. A lot of times we just get kind of non-specific inflammation. So seeing true vasculitis on the sinus biopsy is, we get that about 30% of the time or less. So sometimes we'll pursue it, but that one's honestly a little bit less helpful, especially if it's negative. Sometimes we'll do nerve muscle biopsies in patients who have that vasculitic neuropathy or that numbness weakness that sometimes we see. Imaging is also very helpful in diagnosing GPA. Sometimes we'll start with a chest x-ray, but frequently a CT scan of the chest is a little bit more helpful in looking at the different types of inflammation that could be present. Sometimes we'll see things like nodules with GPA, but then sometimes we'll see what's called ground glass opacities, which is just kind of this like fuzzy appearance on the CT scan that can be due to inflammation or even bleeding into the lungs. We'll also frequently get CT scans of the sinuses, or sometimes if the eyes are involved, we'll do various different types of eye imaging, like an MRI of the eyes, for example, or what's called a fluorescein angiogram, which is something that looks at that retina, the back part of the eye. Sometimes different procedures are required. Bronchoscopy, for example, which is a procedure where they look down into the lungs. Sometimes they'll take samples in the lungs. Sometimes they'll take fluid samples from the lungs. And so if people have lung involvement, that can be quite helpful. Sometimes we'll do things like an EMG or nerve conduction study in patients who have numbness and weakness. And I didn't put it here, but actually like a laryngoscopy or a scope into the sinuses and the larynx, which is the top part of the throat. That's actually really helpful and incredibly important in many of these cases. So I should have added that one to the procedures. Oh. Okay. Okay. So once we've decided that we think that this patient very likely has GPA, what do we do? So there's kind of two different ways to look at this disease. And I'm pulling this mostly from the ACR Vasculitis Foundation guidelines, which divided our treatment strategies into severe disease and non-severe disease. When we say things like severe disease, we always mean kidney disease. We sometimes mean lung disease, so that more severe lung disease, especially when there's bleeding into the lungs. That peripheral nerve disease, I also qualify as severe disease as well. When we're talking about non-severe disease, frequently that's that sinus disease, for example, that's the most common non-severe disease. So, but right here, we're going to focus on the severe disease. So we divide the treatment of severe disease and non-severe disease as well into two different phases. So there's an induction phase, which is the very first time that we treat a patient, and the maintenance phase. So the induction phase is where we work really hard to get the disease into remission. And so we give people a lot more immunosuppression up front to try to really knock down the immune system and give the try to put the disease into as complete a remission as possible. So that includes a number of things. It includes steroids. The steroids can be given either IV, like through the vein, initially or orally, and there's usually a high dose up front and then a gradual taper over some period of time, depending on which different protocol we're using. Steroids are a really good short-term medication, a really bad long-term medication. They work really quickly, but they have a lot of side effects. And I'm sure many of the people here have experienced those side effects. And so while they're very effective medications, we always try to also at the same time start other medications that are safer in the long term and have a lower risk of those types of side effects. The most common additional medications for severe disease are rituximab, which is the preferred medication at this point, and cyclophosphamide, which was the very first medication that was ever described to help with these types of vasculitis. In addition to the steroids. So both of those medications are given IV. Rituximab is typically given once and then again 2 weeks later. The cyclophosphamide is given IV, and it depends on the type of protocol that's being used, anywhere from every 2 weeks to every 4 weeks. The rituximab lasts for 6 months in most cases. Sometimes we give it every 4 months, as we'll talk about in the maintenance phase, but the cyclophosphamide is continued for somewhere between 3 and 6 months for our initial induction. Some patients will also receive a medication called avacopan. Avacopan is our newest medication for ANCA-associated vasculitis. It was approved, I believe, in 2021 due to a trial where the trial is called the Advocate trial, and they tried to see if patients could take avacopan instead of steroids, and with the goal being to try to really minimize the amount of steroids that patients can get. However, when the FDA approved it, they looked at the trial and they saw that a lot of patients ultimately received quite a bit of what we call non-protocol steroids, which means steroids that they got early in the disease course, even when they were taking avacopan. And so they approved it more as an adjunctive or add-on therapy, as opposed to a complete replacement for steroids. So most of us in the vasculitis space use it as a way to very quickly taper the steroids, usually over 4 to 6 weeks, as opposed to over 4+ months when we were using steroids alone. Another procedure or treatment that is sometimes used in the treatment of very severe disease is plasmapheresis. Plasmapheresis is kind of like dialysis, where we're basically removing the blood from the body, filtering it, removing some of those like antibodies, like the ANCA antibodies, and then putting it back in. There was a really big trial that looked at the use of plasmapheresis in ANCA vasculitis and didn't see a significant benefit in the vast majority of patients. There is still a couple of very small groups of patients where plasmapheresis may be helpful, and it is still used in a very small percentage of patients. But the vast majority of patients, plasmapheresis really isn't indicated. But it is kind of kept in reserve for patients who, for example, aren't responding to the therapy, or we need kind of additional options. Once we complete that induction phase, which is really that first 6 months of therapy, then we move into the maintenance phase. The current medication that's preferred for the maintenance phase is actually rituximab. It's the same medication that we use for induction. Rituximab is typically given by 1 infusion instead of 2 infusions, 1 infusion every 4 to 6 months, usually for a minimum of 2 years. And I always tell patients it's a minimum of 2 years because some very good studies have shown that if we stop it sooner than 2 years, there's a higher risk of relapse. After 2 years, it's really a discussion between me and the patient as to decide if we continue the rituximab, and that depends on how things have gone over the past 2 years, versus if we stop treatment altogether or we de-escalate to an alternative, less immunosuppressive medication. For patients that don't tolerate rituximab, or rituximab isn't a good choice for whatever reason, there are alternative options. Typically, we use either azathioprine or methotrexate. These are both oral medications that are effective maintenance therapies for ANCA vasculitis, and those 2 medications have equal efficacy. We prefer those over mycophenolate, which has a little bit less efficacy compared to those 2, but it still remains like a third-line option for our maintenance therapies. The choice of this medication is very person dependent. It depends on the way that their disease has progressed, the types of symptoms that they have, the areas of their body that are involved. And there certainly are reasons that various different people can't take any of these 4 medications. And so these are the general guidelines, but everything here is personalized for each individual patient. Once we're in the maintenance phase, we want to try to minimize the toxicity of steroids. And so our goal should always be to try to taper steroids to 5 milligrams or less. Some patients will still need kind of a low dose of steroids, like, between like 2 and 5 milligrams, for example. In the long term, the risk of that level of steroids in the long term is low to the much higher doses. So we really, really do try to get to 5 milligrams or less. There's this question about, should we continue avacopan in these patients? The initial trial for avacopan was 1 year long, but we don't know about its use as a maintenance agent at this point. There are clinical trials that are ongoing right now to try to figure out if it can be used as a maintenance agent, but that's similarly a discussion to have with the patient and the rheumatologist, and to have shared decision-making there. In patients who have had flares of their disease, like very early, for example, sometimes we end up needing to add another medication to the rituximab. And sometimes that's those other medications I mentioned earlier, things like azathioprine or methotrexate or mycophenolate, just to add a little bit more immunosuppression with a different mechanism to try to better get the disease under good control. And we really do want to try to get people into remission, meaning like no disease activity, and they're kind of living their normal lives and feeling good with the use of these medications. Okay, so moving on to the treatment of non-severe disease. This is going to look kind of similar to the treatment of severe disease with a couple of caveats. So for induction phase, most people with non-severe disease don't need IV steroids, so they'll just get oral steroids on a taper, so starting at a higher dose and then going to a lower dose. And then so the current preferred agent for non-severe disease is methotrexate, but similarly, all of the other medications that we've already talked about are options. So azathioprine, rituximab, and mycophenolate. And again, that's very person dependent. It depends on like the extent of the disease and about the preferences of that person. And then plus minus the use of avacopan. Similarly, at this point, I'm offering it to all patients with both severe and non-severe disease, because both groups were tested within that clinical trial. The maintenance phase for patients who have non-severe disease, we usually continue whatever agent we used to induce remission. So if a patient started with methotrexate and they've done well with methotrexate and their disease activity is very low, we'll continue that agent. And similarly, we have a goal of trying to taper the steroids to 5 milligrams or less. We're trying to decide about the continuation of avacopan or not, and sometimes we do need to add an additional immunosuppressive agent if they continue to have flares despite our induction therapy. I usually tell patients, especially when they're diagnosed with more severe forms of GPA, that we really have to give it the full year of induction, because that first year is critically important in figuring out how well people are going to do in the long term. The better job we do of getting the disease under good control within year one, the less likely people are to relapse or flare in the future, and the less likely people are to have ongoing damage from the disease in the future. And so I try to tell people to really dedicate themselves to their health within that first year so that we can work together and get the disease as under good of control as we possibly can. Those agents aren't the only thing that's important when we treat patients with vasculitis, because as likely everyone here is aware, all of those agents are immunosuppressive, and that's by design. They suppress the immune system so that like it's no longer attacking your body, attacking yourself, and that can cause these various different issues. So it increases the risk of infection. The most serious infection that we sometimes see in patients who have high doses of steroids or are using high doses of steroids is pneumocystis or PJP. So all patients who are on greater than 20 milligrams of prednisone for more than 4 weeks, any dose of cyclophosphamide, and ongoing rituximab therapy should get pneumocystis prophylaxis. That's typically done with trimethoprim sulfa, dapsone, or atovaquone. There's a star by the rituximab therapy because in our current Vasculitis Foundation guidelines, it's recommended to do the pneumocystis prophylaxis with patients who are on rituximab therapy, but there is some disagreement between those guidelines and the Infectious Disease Society of America, where they don't currently advise for the use of pneumocystis prophylaxis with all patients on rituximab. However, patients, especially with pulmonary disease related to ANCA vasculitis, do seem to be at a higher risk. So this is definitely like a risk-benefit discussion between the patient and the provider. We also want to try to mitigate steroid side effects as best as we can. So bone health, we frequently add things like calcium and vitamin D supplements or other treatments in patients that already have thin bones, like osteoporosis, for example. Steroids increase the blood sugar, so it's really important that we try to manage the blood sugar as best we can to prevent worsening or new onset diabetes. Trying to get really good sleep is important because steroids can cause insomnia in a lot of cases. So taking that prednisone in the morning is really important. And also mental health. Steroids can be a lot on like people's mental health. It can cause anxiety, depression. And so making sure that patients have good access to mental health resources and support is really important. Okay, a plug for treatment of sinus disease, which is super, super important. We talked about how about 90% of patients have sinus involvement. And so care of the sinuses is really important. So, and especially because some of those oral and IV medications that we just mentioned don't actually adequately penetrate the sinuses. There's certain areas in the body that are these kind of like protected areas by your immune system that's actually quite hard for medications to get into. And so it's really, really important that in addition to taking the oral or IV medications, that patients take otherwise good care of the sinuses. So things like saline rinses, those saline rinses can include steroids, they can include antibiotics, and it's really important for patients to do them regularly. In patients who have had more destructive sinus disease, reconstructive surgery is an option if it's desired by the patient. And then regular exams with their ear, nose, and throat doctor is critical. And similarly, for like the rest of our disease monitoring, regular visits with rheumatologists and all of the other subspecialties on the team is also really important. So nephrology with kidney involvement, pulmonology with lung involvement, ENT involvement for all of our sinus issues, neurology, and infectious disease if there are infectious complications. Most patients with vasculitis need routine labs, usually every 1 to 3 months, depending on the stability. Kind of 3 months is usually the standard once things are stable. We also want to monitor for and treat any infections that come up because of the patient's immunosuppressed status. We want to make sure patients are getting appropriately vaccinated at the appropriate times, or those vaccines are going to be very effective. And we want to monitor for a condition called hypogammaglobulinemia, which is low IgG levels in patients who are on rituximab in the long term. This can further increase the risk of infection, even more than just the use of rituximab by itself. And sometimes we treat that with things like IVIG, which is another medication to help boost up the IgG levels. Okay. I do a lot of work in reproductive health, and so this is super, super important to me. It is critically important to discuss plans and desires for pregnancy at every single stage of treatment. This is something I ask all patients who can get pregnant during all of our visits. Many of the medications we use are teratogenic, which means they can cause birth defects. Cyclophosphamide in particular can impair future fertility, and so we really try to avoid it in anybody who wants to get pregnant in the future. Ideally, we want to plan and pursue pregnancy when disease is well controlled and patients are stable on pregnancy-compatible medications, meaning medications that are safe to be on during pregnancy or breastfeeding. If a pregnancy is not desired and teratogenic medications are being used, it's really important that patients are on highly effective contraceptives. And any patient that is pursuing pregnancy needs to be monitored with a high-risk obstetrics doctor, sometimes called maternal fetal medicine specialist, throughout their pregnancy, in addition to their rheumatologist. Okay. And then lastly, I just want to touch on some upcoming and ongoing research. I would say, there was kind of a 30-year drought in terms of treatments for ANCA vasculitis between the times when we got cyclophosphamide in the 1970s to like the early 2000s, when more options started to become available. But now there are so many additional treatments and additional clinical trials going on in ANCA vasculitis. It's a really exciting time to be working in this space. So there's a lot of different things looking at our alternative induction therapies. So medications like obinutuzumab, which is kind of like a stronger version of rituximab, telitacicept, and I'm going to mess up this name, tarperpermig, which is a challenging one to say, which are two different biologic agents that are also being investigated for induction therapy. You might have heard about CAR T-cell therapy. CAR T-cell therapy is kind of the deepest way that we can deplete B cells, which is one of the things that rituximab does. But CAR T-cell therapy is like a really aggressive way to do that. There's a couple of different types of CAR T-cell therapy, but a number of different companies are looking to use these therapies in ANCA vasculitis, as well as other ways to inhibit the complement pathway, which is what avacopan does. There's a couple of other different medications being investigated in that space. There's also a lot of interest in how do we maintain remission in patients. So the long-term use of avacopan, for example, is something that's being investigated. How often or how do we redose rituximab has been a topic of discussion for many years, and there's still more investigation into that that's ongoing. Similarly, appropriate steroid regimens. How much steroids do patients need is an ongoing question. We use a lot less steroids now than we did in the past, but it is one of those things that I think we'll continue to iterate on until we find the most appropriate regimen. And then similarly, just a plug for my own research, is the impact of medication use during pregnancy. Because so many of the drugs that we had traditionally used for ANCA vasculitis really were not compatible at all with pregnancy, patients now have a lot more opportunity to pursue pregnancy. And so, but we also, because these diseases are rare in pregnancy, and patients who have these diseases is even rarer, we don't really know the impact of medication use on pregnancy and on things like timing of delivery, things like preeclampsia, for example, and neonatal outcomes. So that's a lot of the work that we're doing, but not enough is known in that space. Additional resources for patients. So all of the people here already know all of the wonderful Vasculitis Foundation resources because you found your way to this webinar. But I love the Vasculitis Foundation. I think they do such an incredible job providing high quality information to patients. And there's so many different ways to get involved. Their website has great like information for patients that's not written in like medicalese, which can be very hard to read. I always tell people the internet's a really scary place for medicine, and so you want to find all of your information on high quality sources. And the Vasculitis Foundation is the highest quality source for information for patients. I've already highlighted well, actually I didn't, I should have, the Vasculitis Pregnancy Registry, or the VPPRN, which is a ongoing prospective registry for patients who have vasculitis who are pursuing pregnancy. And that's really to find out those questions about pregnancy outcomes and what happens to patients who have vasculitis during their pregnancy, what medications they take, what medications are safe. And so this is really great, especially for anyone who's considering pregnancy. You can be part of this effort. It's really, really important. It adds tons of very high quality data. Similarly, the Vasculitis Patient Powered Research Network, the VPPRN, also great. There's now a pediatric version, which just launched like 2 weeks ago, I think, which really empowers patients to be part of vasculitis research. They pitch different ideas. They are active participants in all of these different studies, especially in like trying to highlight what things are most important for patients, like what things are important for patients to know and understand, like what are the gaps in the literature that we still need to know that are critically important to patients, even more than things like the clinical trials that we're doing. So these are really incredible resources for patients and their families. Okay, and I think that's my last slide. So yeah, I think we can open it up to questions. Thanks everybody so much.
Well, great. Thank you so much. That was so thorough. I had a few questions written down on my own, and you answered them all in your presentation. So, but honestly, we have quite a few questions in the Q&A box. We're going to try to get to as many as we can. They're all really good, I must say. So let's start with the first one, if you don't mind. Is there information available about women in menopause taking transdermal hormone replacement therapy and the risk of blood clots? My understanding, the risk is lower when using transdermal. Is that correct? I would love to have information to share with my doctors.
Yeah, so there's not great data in terms of the use of transdermal or really most hormone replacement therapies with vasculitis specifically. A lot of it depends on people's prior history of blood clots and other things like smoking, for example, prior tobacco use. The risk of blood clots with transdermal estrogen, I agree. And again, that's not my specific area of expertise, but of course I have patients who are in menopause. So this is something that I have definitely had to look into, especially in people who don't have a history of blood clots, is relatively low. However, in patients who do have a history of blood clots, that's something that's really important to talk to your doctor about the pros and cons of.
Okay, thank you. It's always great to check with your own physician to get the answer that's correct for you. And now let's move to the next question, which is, does persistent elevated ANCA titer without classic findings of vasculitis have clinical significance?
That's a great question, and something
Mhm.
that's like been debated within the vasculitis space for a really long time. There was a time in like the 2010s where people were tracking ANCA titers more regularly because they felt that, and there was some data to support that ANCA titers were trending with disease activity. However, several subsequent studies have shown that in a lot of patients it doesn't trend with disease activity. And so it's actually within our current guidelines not recommended to trend ANCA titers routinely. And I personally, I don't do it in the vast majority of my patients because I think it honestly causes more anxiety than anything else. If you see those ANCA titers go up, but you're feeling fine, I'm actually not going to do anything about it if the rest of your labs look good and you're not having any new symptoms. But I think it gives people a lot of anxiety. And the reality of our data is that those titers fluctuate over time. And while in a small percentage of patients, it may trend with disease activity, in the vast majority of patients, it's not a good enough correlation to trend them routinely.
Okay, thank you for answering that. The next question is pretty normal in all of our webinars. Why does extreme fatigue linger even after you're in long-term remission? More exercise makes it worse. What do you recommend? I just want to say, as a victory over vasculitis person for the Vasculitis Foundation, more exercise does not always make it worse, but it can for individuals. So please, Dr. Hornomanski, if you have some info, that would be great.
Yeah, fatigue is one of the hardest symptoms in all of autoimmune diseases, and that's not vasculitis specific. We see this in lupus, we see it in rheumatoid arthritis, for example, that as the person who wrote this question noted, many patients have completely no evidence of the vasculitis being active, but we'll still have this persistent fatigue. And sometimes we try to tease out if that's related to the medication use, because sometimes that's it, right? Medications can cause fatigue as a side effect. Is it related to other things like sleep quality? Or could it just be that the vasculitis is still kind of smoldering, for example? But sometimes we really can't find a clear and good answer for that. And the treatment for it varies person to person. I think the question writer mentioned sometimes exercise for them makes it worse. Some people like routine and regular exercise actually helps the chronic fatigue. We end up pulling things from the chronic fatigue syndrome literature quite a bit because they have a little bit more experience in this. But there's actually, I think, I can't remember if it's ongoing study by the VPPRN in regards to fatigue or if it is completed at this point. But this is like a really important question, something that is like actively being asked. Sometimes I'll treat patients with things like low dose naltrexone, which is not an FDA approved therapy for this in any way, but it is used in chronic fatigue syndrome. And so sometimes we'll give people a trial of that to see if it helps, but the literature behind that is very lacking at this point.
Okay, thank you for answering that. I did want to add that we have done a couple of webinars recently about fatigue. They're very, very helpful. I'd encourage you to go to the YouTube channel for the Vasculitis Foundation and look for those. And Dr. Hornomanski, if could I ask you to go 5 minutes over? We have a lot
Yeah,
of questions here.
yeah, no problem.
And honestly, I want to tell everybody, if you're putting your questions in the chat box, I'm missing them. They need to go in the Q&A box, but we will keep track of all these questions. Anything we don't get to today, we will appeal to Dr. Hormansky to help us get those questions answered at a later date. We've done this many times in webinars that we just couldn't get to them all. But thank you all. I love this next question. As the director of the Stanford Vasculitis Clinic, do you participate in any educational sessions with your ENT providers to identify symptoms quicker and minimize the diagnosis time for GPA patients?
Yes, definitely. And so I am fortunate enough to be at a center where I have two ENT specialists that specialize in GPA, which is actually incredibly rare, but they love seeing these patients. We share all of these patients together and we do educational initiatives with all of the other ENT doctors within our group to try to make sure that everybody can recognize GPA. But I do think that there is a need for efforts more broadly in my space in California. The Central Valley, for example, because of a lot of the agriculture there has so much allergens that are just in the air. And so they're very used to seeing, the ENT doctors in that space are very used to seeing like chronic allergic sinus disease or chronic sinus infections. And those are the areas where I see most patients get missed for a really long time. And so I do think that there's more work that we can do in terms of outreach to areas where there are fewer rheumatologists.
Well, thank you for that. We hope all ENTs are learning about vasculitis. Um, I'm going to put two questions together now. One of them is, once you're ANCA positive, are you always ANCA positive, even in remission? And the second one is, can you be ANCA positive and not have GPA, eGPA, or MPA? If so, what would the cause be?
Great questions. Okay. If you are ANCA positive and you have a diagnosis of ANCA vasculitis, that ANCA titer can become negative at some point in the disease. In a lot of patients, it is, but in also a lot of patients, it will be positive for forever. And again, I think that causes more anxiety when we test it than actually like good clinical information and help. Because again, some people it's just always going to be positive. And similarly, that's true across most of our autoimmune diseases. For example, in patients who have lupus, their ANA is always going to be positive for the rest of their life, no matter how good of control we have under the disease. And then the second question is actually a really important question: is if you're ANCA positive, does that mean you have ANCA vasculitis? And the answer is no. Is that there are a lot of patients who are ANCA positive that don't have ANCA vasculitis. Sometimes different medications can cause ANCA positivity. Different infections can be associated with ANCA positivity. Different conditions, so things like ulcerative colitis or inflammatory bowel disease, Crohn's disease, those patients also frequently have positive ANCAs. It's usually a p-ANCA titer or what's called an indeterminate dominant p-ANCA titer. But a lot of patients with inflammatory bowel disease will also have positive ANCAs. And so it's really important that everybody who has a positive ANCA isn't immediately diagnosed with ANCA vasculitis, because there are all these other things that we want to make sure that we are either ruling in or ruling out so that we're treating patients appropriately.
Thank you for clarifying that for us. The next question is long-term use in terms of years of methotrexate considered safe for GPA to keep it in remission?
A great question. So we started using methotrexate for GPA in like the late 90s. And so we have good data from that time. But we have even more data from the other autoimmune diseases that we treat. And so things like rheumatoid arthritis have been using methotrexate to treat that disease, which is a chronic and relapsing disease, for even longer than that. And we have data that suggests that it is safe in the long term, as long as patients are getting appropriate lab monitoring, watching their liver enzymes, making sure their white blood cell counts are very well monitored. But the risk of those side effects in patients who've been on it for a long time is actually quite low. The majority of those laboratory abnormalities we see actually quite early in the use of various medications. But we don't see a significant cumulative long-term risk associated with methotrexate.
Okay, great. Thanks. This question did cross my mind, and somebody has asked it. What is the distinction between severe and non-severe disease?
Yeah. So generally, it's organ threatening. And so if there's a possibility that the vasculitis could threaten the function of an organ and potentially be either organ threatening or life threatening, then we usually classify it as severe disease. So any patient who has kidney disease classifies as severe disease, because we really don't want patients to progress to kidney dysfunction and then dialysis. Any patients with severe lung disease, especially ones that require hospitalization, that qualifies as severe disease. But then there's all these other areas that aren't explicitly outlined in our guidelines that I would definitely qualify as severe disease. So patients who have neurologic involvement, patients who have any brain involvement, for example, I classify as severe disease. The rare patients that have cardiac involvement, I classify as severe disease. So a little bit of it is semantics. But we kind of look at what's the worst thing that can happen with the vasculitis in this organ, and should I treat them as severe or non-severe?
Okay, great. Thanks for clearing that up. This next question, I'm going to paraphrase a little because it is a specific medication question, so I think I can generalize it. The person is asking, saying that his or her nephrologist says they can stop using rituximab in 6 months and go to once a year. And the rheumatologist says I need to do it every 6 months. And I think the question is, you know, who should I listen to, or what to do after remission? Thoughts?
It's a great question.
I know we tell people to ask their doctors, but she's got two different answers, or
Right.
they.
And that can be tricky. I think when you have two different conflicting answers, it can be hard. I think that answer to that specific question depends on so many things. It's hard to answer
Yeah.
specifically. Because it depends on how long you've been on rituximab, how has the disease flared, what parts of the body has the disease affected. After quite a period of time of remission with the rituximab every 6 months, sometimes if patients can't or don't want to de-escalate to a different medication or feel uncomfortable with stopping medication, sometimes we'll space rituximab out to a year. But generally, it's best when dosed every 6 months. That's usually, and again, we actually don't have a great study that tells us how to do this, how to stop or space out rituximab in the longer term after patients have been in remission for a really long period of time. And so I think it's possible that both approaches have merit and reason, and it really depends on the patient.
Yeah, we often in these webinars, tell patients that you just have to talk to your doctor and tell them what's important in your life.
Yep.
And then you get to make the decision, it sounds like, at this point, based on what Dr. Hornomanski just said. Okay, next question. Do you ever see a delay between symptoms in patients and elevation of labs reflecting inflammation? And what's the typical time frame between onset of symptoms and reflecting inflammation in the labs?
Yeah, so I guess it's important to note that sometimes the ANCA tests can be positive before people develop symptoms. That's true in a lot of autoimmune diseases. So sometimes people will have that ANCA test and then will later go on to develop the disease. If you're talking about inflammation, like inflammatory markers, those are things like your ESR and CRP. Those usually go up when people start having symptoms, but rarely sometimes we see them come up even before people start feeling bad as kind of uh, a sign that a flare could be brewing. And I do take those seriously, but we don't want to just treat the elevated inflammatory markers without another area where the disease is clearly active, because then we end up kind of inappropriately treating people, giving people more immunosuppression than they need, and that has real harm associated with it.
Well, I hate to say this, everybody, but we have run out of time and run over, and we want to be mindful of Dr. Hormanski's time. Thank you so much for working with us today. Just before we finish up today, I want to share a few things that might help us with a little bit more information. Not that Dr. Hormanski didn't give us so much information, it was great. I want to remind all of our viewers to visit Vasculitis Foundation website, as she was saying, where you can find all kinds of helpful information about vasculitis. For instance, under education, you can learn more about the various forms of vasculitis. As a matter of fact, after you've read about it, particularly your form of vasculitis, you can go to the resources tab, and under order print, you can find a short document that you can print out for family or even take to your primary care doctor's office. People are getting sick of me saying this, but I took it to my dentist's office recently, and I say it in every webinar. On the VF website, you'll also find a video library with all of the recorded webinars on the homepage. So you can find out more about the patient support groups, upcoming events like these webinars, as well as Vasculitis Foundation conferences. I was at the one in South Carolina this past weekend. It was great. And then next, I want to say that be sure to check out the new improved Find a Doctor tab. There's a database on the website. You can do a search of all healthcare providers with experience diagnosing and treating vasculitis. Now you can click on the Find a Doctor button, and it'll take you to a step where you can enter your location and then filters of what kind of doctors fit your needs. It's a great new tool to help us all find the proper providers for our form of vasculitis. That's a very common question. How do I find the right doctor? So we hope that this will help you with that. And then next, I want to talk about something that's coming up soon. It's gone out in the newsletter. If you've gotten it, you would have just seen it. Navigating Your Vasculitis Journey is a course which is a live 6-week virtual learning opportunity offering behavioral strategies to help those who have recently been diagnosed with vasculitis to manage life and chronic illness. Using the Navigating Your Vasculitis Journey guidebook, that's 135 pages. I printed it out to take to the conference last weekend. This free course brings participants together for a 6-weekly 90-minute Zoom session to connect, learn, and grow in a supportive setting. Sessions will be held on Thursdays from 10 a.m. to 11:30 a.m. Central Time, beginning January 22nd, every Thursday, and running through February 26th, 2026. So participation in the course is limited. Those who can commit to attending each week will be looked at and interviewed. The applications have to be received by December 5th. If you click on your screen, the link should pop up there for you. And I think Ed's also putting it in the chat area. And then finally, I just want to say thank you so much to all our viewers and to Dr. Hormanski. We appreciate her time. And I also want to say that if you, as soon as we're done today, a survey is going to pop up. So when you see the word continue, please click the word continue, take the survey. One thing we especially want to hear is about your ideas for future webinars. In fact, today's webinar is a result of the survey. We had so many people asking for a GPA webinar. That's why we did today's webinar. So click that button that says continue and take the survey. Each person registered for today's webinar will also receive a follow-up email with a link to the recorded version as soon as it becomes available. And so thank you so much to the Vasculitis Foundation for hosting these webinars. And of course, Dr. Hormanski, thank you for your time today. We greatly appreciate you. and our sponsor, Novartis, for supporting these webinars. Thank you, everybody.
Thanks for having me. Great to meet everybody.
It was great. Thank you.